Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health. Hello again, everyone, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and I'm pretty excited for this episode, honestly, because we're going all the way back to day one. Dr. Luis Hernandez, thank you for coming back, Doctor. It's been a long time since I've seen you.
I know. I feel that has been forever. At least 2-3 years.
At least. You were you were the very first Doc Talk podcast that we did. We had 3 episodes with you talking about the heart, which is what we're going to talk about today. Yeah. But you've had those 2 or 3 years since you've been here has been quite a journey for you, hasn't it?
Yep. Yeah, a lot of things have changed.
Where has it taken you, Doctor?
So I think the last time I saw you, I was actually accepted for fellowship at Cleveland Clinic in Cleveland. So I went back and did advanced heart failure and transplant, which is it's like in a subspecialty of heart failure, of cardiology, sorry.
Yes.
And I did a year of training there, so I can come back as an advanced heart failure and transplant cardiologist, which is just a long title. That's what I tell people. But yeah, I always try to tell people just heart failure because it's easy to understand in the long, you know, and some people get scared when you say transplant. So I always say, well, I'm a heart failure cardiologist. That's how I describe. But the degree is actually all the big name I just told you. Yeah.
So why? What motivated you to do this? Was it something you've wanted to do since you started in the profession?
Yes, it was my dream actually. When I applied to the job here, the application here says someone who wants to do heart failure or was interested in heart failure. So I always knew I needed to do this, but I didn't have the chance to do it. And then as soon as I started here at Monument, a month later, they say, oh, do you want to come and do it? And I was like, yeah, why not? And then, everything ball rolling. And then, I got accepted and it just went. So you were gone there. It took about a year to do that fellowship you were in Cleveland is where you went? Okay. Mm-hmm. Yep. Yeah, it's a total 1 year.
Okay. Then because you had mentioned a fellowship, and I think the times we've talked about that with doctors on here, people kind of know what that means. It means you're just trained more in your specialty, correct? Yep. But you have an advanced fellowship. Yep. So what is that, Doctor?
So it basically means, residency means that you did your first specialty. Yeah. And then that specialty is divided in other specialties, right? So my fellowship is general cardiology, basically. And then from general cardiology, we have a bunch of specialties. We have imaging, interventional, structural, heart failure and transplant, electrophysiology. So it's another specialty, basically. So depending which one you're picking, and in my case, it's only 1 year. EP, for example, or electrical doctors, it's 2 years. So it depends which one you pick. So after your 3 years of internal medicine, 3 years of cardiology, an extra year or 2 of advanced fellowships.
Now, did you do this specifically knowing you were going to return to Monument Health?
Yep.
Okay.
Yep.
So there was no chance anybody was going to steal you away after this was done?
Exactly. That's how I convinced them. I said, you guys have been looking for someone like me, and this is perfect. I said, I like rapid. I want to come back. And it was a perfect, opportunity. Basically, Cleveland Clinic is the best place to train in heart disease. If you read it for the last 24 years, best place, number 1 in the whole country. Wow! So for us, as a team, was an amazing opportunity. For me, it was a big opportunity, a huge opportunity, and I couldn't say no.
Well, I've seen that the Heart and Vascular Institute has won some awards from Cleveland and from Mayo. Yep. So you guys are doing wonderful things.
I tell people, not because I work here. I said we have everything you need, and for me, the only thing we don't have is transplant, Right. But we have ways, and I'm going to talk a little bit about it, how we do it. But we have ways to get people for transplant if we need them.
Okay. Yeah. And you are, like I said, it's the advanced heart failure and transplant, and you're one of 2 doctors in the state, but you're only one of one when it comes to the transplant, correct?
To the training.
The training of this, yes.
Yep. So years ago, old docs we didn't have fellowships, right? So heart failure and transplant is a new fellowship. So the other one that is here in Rapid City didn't have a formal training like I did. So that's the only difference.
Okay.
Yep.
Well, that's still nice to have on your wall, though, in your office there, for sure. Well, as when this podcast airs, Doctor, it will be Heart Month. It'll be February, and they actually have a week within Heart Month that is Heart Failure Awareness Week.
Yep.
Which is something that we're going to be talking about right now. And as I was kind of putting this together and looking at the questions, Doctor, I don't like the word failure in any of this, right?
Nobody likes it.
Right. That seems to be the scariest part of this. Advanced heart failure. I mean, obviously, it's something that sounds very serious. So can you kind of break it down for us? And what makes it different from the earlier stages of heart failure?
Well, that's a good question. So heart failure basically, as I think I mentioned to you in my first podcast,
all the way back at the beginning,
it's divided in a weak heart versus a normal heart, right? So we're going to focus on the weak hearts. And we divide heart failure, we call it systolic heart failure, based on stages. And stages are depending what it helps us to determine where you are. So stage basically A is, you don't have any symptoms at all. You're kind of like at risk of having heart failure. Stage B is those patients who had structural changes in the heart, elevations in blood enzymes, but no really, there can be not really that symptomatic. And then we have stage C, who patients are really symptomatic. Those are the most common ones. Heart is weak, patients having symptoms. And then the last one is advanced, so which is stage D. So stage D is basically those patients who are very limited because of the symptoms related to heart failure. And these are the patients, and the term advanced heart failure, right? It means, that's the difference in stages. Advanced heart failure means that really you already tried everything and the heart is already weak enough that you just require a transplant or a heart pump, or sometimes if patients are very sick, hospice care. So it depends where we are. And that's one of the things I always want people to understand. We can try to reverse this if we can. That's our goal. That's my team. We work harder for that. But advance means advance. It means that we're already there and we need something else. Believe me or not, there's so many things we can do and probably get you from there out of the advance, but sometimes when it's already there, it's hard to go back.
Well, that's good to hear, though. It's good to hear that there's still a chance, I guess. Let's put it that way. Yeah. So what are some of these red flags that people should watch for when it comes to advanced heart failure?
Yeah, so the most common symptoms is people will start getting leg swelling. They will get out of breath when they walk. They will get out of breath at rest, especially when they're laying flat because they accumulated water. These people will feel very fatigued. They're not able to do a lot of things, the daily things they used to do before. They don't do it anymore because they will walk a little bit. They will get out of breath. So they stop doing what they want in their life, and that's where advanced heart failure training comes in, right? Because my goal is to make sure every one of those patients have a normal life, as normal as they can be. So those are the most common things people complain of. Obviously, if you have a heart attack before, if you have diabetes, those are the things we can prevent. If we can prevent a heart attack, if we can control your diabetes, if we can control your high blood pressure. So that's why we have that stage A where we talk about at risk, right? Where we want to basically kind of like prevent them to go to pre-heart failure. So if we can do prevention, that's always the best option.
Okay, then how do you diagnose advanced heart failure then when it comes in?
So typically we use a lot of things, but we use an ultrasound of the heart.
Okay.
That's the main one. It will tell us if the heart is weak or not. And then depending on, we need to figure out if this is blockage related, because most of the time people will have blockages in the heart. Some people will require stenting. Some people will require like a bypass surgery if they have a lot of blockages. And then we do have people who don't have blockages, which is part of the interesting part too. So like people, for example, with COVID, that's an example about COVID, right? With COVID, the COVID will affect the heart, even as flu. A normal flu can affect the heart too. And sometimes the heart will get weaker. And there is a bunch of other things, alcohol, drugs, name it, is probably a cause, but yeah, that's what I say, people. But my point is, those things, if we can prevent those things or try to figure it out, we can make this better.
Okay. So when someone hears the term advanced heart failure, what does that journey usually look like then? Are there some new approaches beyond medications and surgery that you guys do or are working with?
Yeah. So my goal always is to start with medicines, right? Yeah. Because I always tell people, even if your heart has been weak before, the medicines that we have now are so much better compared to years ago, right? A lot of things has changed. We have new medications. And my speech to people is we use 4 drugs first, which are oral pills. And I call them the 4 pillars. That's how we call it. Good one. And I tell them this is like a building. You have 4 pillars. And if those pillars fall down, one of them fell down, everything fell down. Mm-hmm. I think one of the hardest thing is to explain people you need to take 4 pills, and people don't understand that, and I try to explain them is all of them work together, right? That's why we call them pillars, because they're holding the house together, right? One of them fall, everything fall. So if the medicine doesn't work, then to your question, what else we do, right? Yeah. Sometimes we, depending on how symptomatic they are, the next step is to really see how much the heart is doing. And then typically we do what we call a right heart catheterization, which is basically we put a small tubing in the neck and we measure the pressures in the heart. And that will give me an idea how the heart is behaving. Sometimes the heart can be weak, and I think that's an important point I want to make too, because there's some people who focus on the number. So the number we use, what we call weak hearts, is we use the ejection fraction. So people always think ejection fraction is 100. So it's not 100. It's typically around 60. I always tell people 55 to 65, right? So people focus on that. So when we call it weak heart, typically when the heart function drop less than 50, So those are patients who are in advanced heart failure, typically it's around 25%, right? So from 50 or from 60, however you want to see it, it's 25%. So those are the patients who most likely will qualify for something else, right? So that's the first step. You get an ultrasound, you rule out the blockages, you treat them in medicines. If you're still having symptoms, then we do a cath. So if we find that the numbers are okay, so that means that we still can keep trying the medicine, try to see what else we can do better. Why I bring this up? Again, the number. So people will fixate in the number. Oh, my heart is 30%. My heart is 35%. I'm going to have a crappy life. People can live years with the heart function at 35, a heart function at 40%, 25% even. Obviously, the disease will progress, right? Especially people don't take medicines, especially people do alcohol, they do drugs. Things that, they don't control their diabetes, they don't control their blood pressure. So those are the things people can do to make it better, right? So once we decide, again, that we can hold it, we always want to keep your heart as long as we can. Once we cross that line that, medicine's not working, you're having multiple hospitalizations, this is important. We're trending down the medicine. So people will get happy because, oh my God, they're cutting down my medicine. That's actually not a good sign, just so people get clear about it. Whenever we're cutting down the medicine, it's actually a poor sign, because if your heart is getting stronger, if your heart is getting better, why we're cutting down the medicines? You should not cut. You should actually, you should be able to go up on those medicines. So at least stay where you are. So the main is worsening symptoms, meaning the symptoms are arrest. Those are the symptoms I'm concerned. Multiple hospitalizations because they're coming back with fluid in the legs, with heart failure symptoms, trending down medication. Some people will have a defibrillator when they have this for years, and then they will start getting shock. So those are things, that people is unable to do their normal things they do in typical life. They're requiring more water, diuretics or medicines to make them pee. We call it water pills, but they're not water pills. They're just pills that make you pee. So there's a lot of things, at that point is when I talk to them about heart transplant or heart pumps, or even hospice if that's the case.
Okay. We keep talking about a weak heart. And you've mentioned medications and the steps that, kind of how you guys go down the line. So let's say you have that medication and you take it like you're supposed to and it works fine and you can just take it then the rest of your life. Is that in essence what it is?
That's a good thing that you mentioned.
Yes, exactly.
People ask me about that. And I struggle because people always want to stop the medicine. And I think that's the important point that you asked there. And it's very important. We talk about how important all these pillars, right?
Right.
People always ask me, Dr. Hernandez, if I get better, can I stop these medicines, right? And this is the way I kind of phrase it to them. I think it depends on the reason why your heart got weak. But most of the answer, I had a patient who actually make a joke of me because I always tell her I wouldn't. So the answer to that is I wouldn't stop them. Yeah. And people sometimes don't understand. But we do know now that if your heart got stronger in the medicines, again, everything depends. I do have some patients that I'm okay trying, but they need to understand the consequences. And that's what I always tell them. There are consequences sometimes when we stop these medicines, right? So if we stop the medicines, we know already that 6 months later, at least half of those patients can drop the heart function again. And it's not just about dropping the heart function. It's about it's going to be hard sometimes to even get it back to where it was. Or we won't be able to do it anymore, So I always tell people that's what I say I wouldn't. That's what my patient called me. I wouldn't. Because if you know, and this is the way I kind of phrased them, I said, if you're not having any side effects to these medications, it's not affecting your body. These are medications that have been there, at least, I wasn't even born where they were,
right.
So I'm not talking about a medicine that got invented yesterday, years, right, studies and publications. So I said, if you're not having any side effects, why do you want to stop those medicines? You see, if you tell me that you are having side effects, so it makes sense. You don't have to be an expert for that. And then what I tell people is, you need to let me know so we can work around it. See what else we can do. See if we can change it to another one. But stopping is not the answer.
Well, it does seem like, as somebody, a lot of us, I think, take medication for various, whatever, serious, not so serious, but just to feel better in general. You do reach a point where you're like, I just don't want to have to remember to do this. I don't want to go to the pharmacy anymore. I don't want to have to pick this stuff up. I'm feeling better. Why can't I quit?
Yep.
Right? So I guess my advice, right now you're hearing it from the doctor as to why you shouldn't quit. As long as, like you said, the side effects, I'm sure that's another reason some people want to get off it too. Yeah. But if you don't, if that's as far as you have to go, right? Mm-hmm. Because the next steps are not what you want to take.
Exactly. Right? That's what I tell people. I have some patients that, oh, no, I don't like to take medicines. And I said, well, I just want to let you know, if you do a transplant, you go from 4 pills to like 20.
Right.
So you pick your poison.
Right.
That's the way you can tell people, because if I had to pick a poison, I will prefer 4, rather than 20, right?
Exactly.
Yeah.
Well, let's talk a little bit about palliative care, doctor, and how it's kind of misunderstood in all of this. Can you explain what it is really quick?
Yeah. So basically we have, that's another fellowship.
Oh, good.
Okay. Yeah. That's a fellowship of internal medicine, and it's called palliative and hospice care.
Okay.
Right. So basically, it divides in those two groups, palliative and hospice. Right. So the way I explain it to my patients are, patients who wants to go palliative, the palliative route are those patients who are still not sick enough to die, in the next couple of months. And they offer medications to kind of like help you plan your goals of care, kind of decide in the future, help us to make decisions in the future, what you're going to do with your health in case you get very sick. They help us with medications to keep you comfortable. But again, these are patients who are still not ready to probably die or not there yet. They're not sick enough to choose another option. Then we come with hospice, right? So that's the big word, like everyone already knows, and some people is scared of it. So the difference is most patients in hospice will typically die in the next couple of months, and typically we say around six months, right? And then it's a different approach. I always try to work with hospice, especially in this patient with advanced heart failure, right? Because you want to understand what they want for their life. You want to understand what is their goal. And it is important as part of what I do every day. And I always make like the kind of like the similarity. I don't know if that's the word. I feel like a social worker every day, because we need to figure out your social life. It's not that I ask because I want to know. It's important for me to understand what to do. Even as simple as finance. Some of these drugs are very expensive, and part of the job of my team is to figure out if you can pay for it. It's not just for pay, just insurance, right? Because I don't want. This is how I see it. If I was one of them, right, and the pill is $700, but then I don't have money for my rent and my food, I understand why you're going to pick the rent and the food, right? So my team, I always try to help them to get approved in programs so we can get this medicine. So we ask all these questions so we can help them in the future, but it's more about comfort and trying to figure out what is the goal in life. If you get that sick, how aggressive you want to be in life. And it is important because you need to understand if I send you for a transplant or a heart pump, you need to understand that things can go well because that's the goal, right? Knock on wood. But things can go bad too. Yes. And you need to understand, when to stop. So they actually help us to talk to family about that and help the family and the patient kind of have the same thought process. And obviously we're part of it too.
Right.
But it's a team approach. That's the way I call it.
That's, just hearing you describe it, it's, we talked earlier about starting this show with the word failure, but as I'm listening to more of this,
success.
Yes, exactly.
Yes.
There we go.
Yeah.
So is there hope for preventing or even reversing advanced heart failure? Do you feel like some of that's coming down the pipe a little bit?
Well, this is the way I see it. if you're in stage C, not advanced yet, there's a chance we can reverse it. That's why.
Now, when you say reverse, do you mean legitimately
reverse
it?
Yeah.
Okay.
So you can actually have a weak heart and then go back to normal with medicines.
Wow.
And I can tell you, we talk about it, right, all the time. We used to put defibrillators before when your heart is weak. One of the indications, and still right now, that you need to get a defibrillator. Like our amount of defibrillator had dropped because medicines work.
Yeah.
So but that's what people need to understand. Like now we have so much, we know we know more than before. We have amazing medicines that if you take your medicines, most likely we'll be able to reverse it. Sometimes it's not perfect, and that's why we have advanced therapies, right? But most of the time we can reverse it. I always tell people GDMT means guideline directed medical therapy. So GDMT works. That's what I said.
Oh, excellent. Yeah. So is there exciting things coming up that you're seeing though in research that you're kind of optimistic about? Yeah.
So we do have a lot of research. Monument Health actually, believe it or not, we have a bunch of research, and I think we have a total of, if I'm not wrong, heart failure related at least 6 right now going on with heart failure in different spectrums, not just weak hearts. Normal hearts and weak hearts. I always tell people that we have one of the things I like from here is our multidisciplinary team. So, as I told you, I'm the advanced heart failure. We have imaging guys. We have structural. We have electrophysiology. So we have every single specialty in cardiology basically here.
That's amazing.
So we have everything. We have everything that people. That's what I'm saying. Not because I work here. I think we have everything we need, but everything is reversible if we get it on time. That's what I tell people. Okay, once you cross that line, it's gonna be very hard, and then the only options will be heart transplant and heart pumps.
Okay, so
if you're a candidate, right? Again, what do I mean by being a candidate? So this is the thing is important because some people don't understand what makes you a candidate for this, right? And that's why I talk about, I feel like a social worker, right? For example, if you live alone, that's kind of like a contraindication for advanced therapies because you need extra help, either for a transplant or even for a heart pump, right? And you haven't asked me what a heart pump. I guess you're going to ask me in a second.
I was waiting until you were done with this for sure.
And then living with someone, so you need to have support. You cannot live alone. Obviously finance is important. You don't have to be rich for that, but most insurance will cover even for transplant, even for heart pump. That you don't do drugs. That's important, especially for transplant, not much for pumps, because pumps will just happen in the shelf, right? A transplant is a big deal. So there's a couple of things that people don't realize is important. And I had, when I was in training, there's some patient who got denied just because they decided to do marijuana, a week before. And unfortunately, those are decisions that we make as an adults, right? As simple as that. Alcohol. If you drink alcohol, you have to be sober for 6 months if you want a transplant.
Oh, wow.
So there's so many, like smoking, like simple things that people will imagine, okay, this is nothing. No, those are the things that are important for us to decide if we can help you. Cancer. You have to be cancer-free for a transplant. You can be cancer-free. For a heart pump, it's not a big deal, but you have to have a cancer that is not going to kill you. So there's a lot of limitations to advanced therapies, but I always tell people with advanced therapies, you can actually have a normal life, obviously as normal as they can be, right?
Exactly.
Yeah.
Okay, so tell me, I think we're all familiar with a transplant. Yeah. We're all pretty well versed on that. What is the heart pump, doctor?
Yeah, so that's important. So we have temporal pumps and we have permanent pumps. Obviously, the temporals are the ones that we use when you're acutely sick. And these are the patients who are needing a transplant or, again, at the end of the day, a heart pump, right? These are temporary. We use it for a couple of days, even weeks prior to getting a transplant. And this is something we do in the hospital. You have to stay in the hospital for this. The heart pump, which is called an LVAD or Left Ventricular Assisted Device. So that one is a permanent one. It's a small pump. This is an open heart surgery. They open your chest and they put it in the tip of the heart. And what it does is it will pull blood from the heart and push it into the aorta so it can give blood to the rest of your body. So it's kind of like doing the same job that the heart is doing, but it's just an extra help from the heart.
Why would you need a transplant then?
Well, no. Remember, it's either or, right?
Right.
Yes.
Okay.
But there are some people who cannot qualify for the heart pump. There's a couple of things.
Yes.
Yeah.
Okay.
Yeah. So So that pump, one of the caveats of it is obviously it needs power, right?
Yep.
So it will come with a cable from your belly, and it's connected to like a pack of batteries.
Yeah.
That people can walk at home, doing things they want. They can go to the gym.
Right.
The only main limitation is that you cannot obviously get into a pool because you don't want to get in a pool with that. Yes. And obviously your life will change a little bit if you want to shower. So it's not a perfect thing, and then you have to take blood thinners, which is important to avoid the pump to clot and to prevent strokes. So, it's a big deal.
Yeah.
Either or transplant or pump is a big deal.
Right. Okay. Do you think we'll ever get to a point, doctor, they've tried so many different ways with transplants. Do you think we'll ever truly get to a point where there might be a mechanical heart?
Well, there is already a mechanical heart, a total artificial. It's called total artificial heart.
Okay.
It's just not an easy peasy.
Okay. Yeah.
It's harder than the other one. Than just an LVAD, right? An LVAD just support one side, right?
Okay.
A total artificial heart, you support both ventricles. So remove the heart, they put it in.
So it's a thing already then.
Yeah. The thing is, it's not easy though.
Yeah.
It's high complication rates. It's really like a last resort.
I was gonna say that's a last resort when you're looking for.
And I can tell you, even where I was trained, I never saw one.
Oh,
because
really?
they're very limited. I think they only had done around 90 in the whole world.
Oh, wow.
Yeah, and if I'm not wrong, Arizona is where it was originally invented and where they have done a lot of them.
Oh, wow.
Yeah.
Do you think we'll get there someday? Maybe?
Well,
or is it just too complicated?
I think it's too complicated. Yeah. I do think, this is what I always tell people, right? I do think LVADs will one day, with this special pumps, if they find a way to charge it like the phones,
Yes.
I think that will be the way to go.
Really?
Because mortality-wise, it's only 1 or 2 points different from transplant. To be honest, it's not a lot. And one of the things what bother people is obviously a cable coming out right from you that will put you at risk of infections of the line because the line is coming out to the environment and you can get infected. It's going into your body.
Right.
So if we can get rid of that, I think it's going to become one of the number one things. Because remember, hearts, right? We only have a couple in the whole country.
Yeah.
Those are on the shelf, so you can just grab one, right?
Right.
So if we can one day get there, I think it's going to be ideal.
Well, I mean, that still is good news. I mean, and the way technology happens, you've seen it in your career, how quickly all of this changes.
Yep.
And, it could be in a year or two, you could be seeing a little, I don't know, something solar that's implanted.
Yeah.
Right? Just some little cord that you pop in. Who knows?
Yeah, 1 year or two is too short.
Yeah, sure. Well, I don't know the way you guys work at the Heart and Vascular and the Monument. I don't know. You guys, like I said, you've just received a lot of acclaim lately, and that living here that just feels so good to hear, right? Yeah. Because now we know that we don't have to go to Denver. We don't have to go to Minneapolis. Mostly, we can be treated right here because you guys have put a great team together for sure.
Yeah. So you haven't asked me about how do we do if we need one?
Yes.
Or either a heart pump or So what we do here at Monument, right? It depends the acuity too. That's one thing. If this is something acute that you came very sick, so typically we admit you to the hospital. Depending how sick you are, we can put one of those temporal pumps that I mentioned.
Yes.
And then typically we will send it to a hospital. Most of the time I send them to Minneapolis, but again, it will depend whoever is available. I always try to accommodate patient's family because, again, remember what I told you at the beginning, you need family support, right?
Yes.
And if the family cannot be there, cannot go there, so they will say no, right? Because you need support. So I will always send them wherever the patient lives close by so they can be closer. It's a big deal in the sense that requiring commitment because we're talking about a transplant or a heart pump. Family have to move there for a couple of weeks because even if you get a pump, which is the easiest one compared to a transplant, they still have to train you how to use it. And I always make the joke that patients who had a pump know more than me because they always living with it, right?
Right.
So, they're living with it. And I said, you probably know more than me. That's what I said, because they live with it. So you need to accustom to have that life, understand all the alarms. It's again, it's a big deal.
Right.
It's a life-changing thing. I had a patient so here in Rapid, we have a total right now, I think, well, not in Rapid, around us, I think a total of 8 heart pumps that they're walking around. You probably don't realize it because you don't see it.
Yeah, of course.
I have different ages. I have 19-year-old up to 79.
Oh boy.
Yeah.
I was going to ask you a little bit earlier, but kind of what the age range is for. But I suppose it can happen to anybody.
Anyone, even kids.
I mean, yeah, exactly.
So we still put them in kids too.
Right.
Yeah. That's like a way we can survive. And then to answer your question, why if you get in a pump and it's that good, why not instead of a transplant, right? The way the pump works is it supports one side of the heart. Sometimes when the support is a lot, the other side, which is the right side, will fail.
Oh,
so in those cases, you need a transplant because it means that one side is not going to work.
Okay.
Yeah. And I have seen in my training, you can put both of them, but it's just imagine with 2 cables, double batteries.
You're more machine at that point then, aren't you?
So it's just a big deal, though. It's a big deal.
I'm sure it is.
Yeah.
Well, do you plan on going back and doing any more training, Doctor? You've had enough. And this
I
is what
had
I'm
enough.
gonna do.
I had enough. I told my mom asked me about it, and I said no. I mean, I study all my life basically.
Right. Of course you do.
Basically has been working for the last 2 years and a half, but if you count the year I worked first, and then I went to fellowship, come back another year and a half. But I have been studying my whole life, basically.
Well, what do you do for fun when you're not doing this, Doctor?
I just love hiking. That's why I picked Rapid City. I like the Black Hills.
Yeah, you picked a great place to be, for sure. Excellent. Well, Dr. Luis Hernandez, it was so good to have you come in and talk again. I can't wait to have you back once you get settled and everything. And as that institute continues to grow, people here in Rapid City should absolutely feel wonderful that it's here. And that we got doctors like you that are there making sure everybody's going to be taken care of. So again, thank you for coming in and talking, Doctor, and I can't wait to do it again.
Thank you. Have a great day.